Hello, I am Kevin Anderson,
And I'm Adam Okada.
and we are clinical educators and hosts of the Ask the Educator podcast, brought to you by Healthmark, a Getting a company.
Are you a sterile processing technician, infection preventionist, or biomedical engineer? No matter your role, if you're involved in medical device processing, this podcast is for you. Our goal is to equip you with the knowledge and tools for excellence in medical device processing.
Now let's get started. Hey everyone, welcome back to the Ask the Educator podcast. This is Kevin Anderson, your host, and with me as always, Adam Okada, my co-host. And for this episode, I'm really excited to introduce you to Emily Barnard, and she is going to be a wealth of information. And I want to try and get this introduction and do it justice because I don't want her to have to brag about herself at all. And so I'm going to do it for her. But she is an experienced infection prevention practitioner with over 20 years in healthcare. She earned a bachelor's of science in cell and molecular biology and physiology. She has a chemistry minor with that, and that is from Sonoma State University in 2014, which she wasn't done there. She followed that up with an MPH from Benedictine University in 2018, and she specialized in epidemiology and health management and policy. And then again, she completed a doctoral public health program at Walden University, focusing on innovative research and infection prevention. Additionally, as if that weren't enough, she is also certified in infection control and epidemiology and as a healthcare accreditation and certification professional. So, Emily, I'm so glad you let me read that because it is very impressive resume, and I know how it feels to try and explain all that. It feels like you're bragging, and I know you don't mean it like that, and I know I don't mean it like that. I just mean to show that we have somebody on our show that has credibility and has done a lot in her career. And we are just so thankful to have you on the show. So, Emily, welcome to the Ask the Educator podcast.
Thank you. Just one correction. I'm in the dissertation phase of my PhD. So
Excellent. So it's coming then. That doctor is coming. Excellent.
it's coming.
Yes, that's a process. We know our fearless leader is also holds a doctorate, and we know it was a very difficult and challenging and long process for her. So, kudos to you for going after that. But first, why don't you just tell us a little bit more about yourself, career, personal, whatever you want to share?
Sure. I began in infection prevention really from a personal perspective. Um, my mother ended up developing a deep surgical site infection from a total knee replacement, and really understanding firsthand what those health outcomes look like, what the individual patient perspective is like, and seeing that there's something that we can do. And looking at career opportunities, I thought I was going to go into public health. And then working in healthcare, I realized this is truly my passion. And then I found sterile processing and OR environments. And again, it really had a strong place in my heart. Over this last year, I've transitioned from acute and academic healthcare environments into consulting. And this has been extremely rewarding when you get to work with small healthcare organizations. You get to provide them with unique tools that they didn't have, connect them with Adam. You've been amazing, connecting you with different people, and just in general, getting to really get down to the nitty gritty. And what I think is more important than survey readiness is patient quality and safety. And it's not just why we should do something as being a process and practice, but it's culture, it's relationships. And that's how you really drive change, and changing it from a ding or a survey, infarct, or changing it to an opportunity. And that way it can be
Right.
something that you can work on. How do you learn? You learn from mistakes. And I think that, sometimes we've all heard, well, I haven't been surveyed on that before, or they didn't get us on the last survey. Um, but at the end of the day, there's a patient at the other side. And that's what I like to focus on.
Yeah, and Emily is awesome. So anybody out there looking for IP consulting work, she is incredible. But this episode, we're going to be talking to you about gaps in the process and identifying those things that we don't think about every day. Sometimes they just pop up out of nowhere. And the first one I kind of wanted to ask you about was um, the use of brushes when you're processing multiple scopes. So, as an IP, what are your thoughts on brushes and scopes?
Oh, brushes and scopes are a good topic, especially when you're looking at like a trach peg procedure or um, endocolonoscopy procedure where you're using two scopes in one patient. um, a, a gap in understanding that you could see both from IP and SPD sometimes is, well, it's the same, it's this patient's flora. So why can't we use the same brush? But understanding that the working channels and the working length, those channels are different, and the risk of scratching, gouging, damaging those channels, and also the bioaccumulation. You're potentially increasing the bioburden within that scope. Um, we know that bristles tend to, particularly if you're looking at disposable brushes, those are single use. The bristles can dislodge, they can become trapped in some of those channels, and um, the more frequently it's used, the more likely you are to damage and dislodge some of those bristles. So, really, it should be one brush per scope. It doesn't matter if it's um, an a bronchoscopy, if it's a endo, it doesn't matter what procedure it is. If it's a flexible lumen endoscope and you're using a single use brush, you should really make sure that you're looking at the right brush. But in addition to that, look at the surroundings. Where are they stored? One of the biggest problems is if you've got brushes that look very similar and you're pulling it and you're just looking at a clear package and a small print, it's easy to grab the wrong brush. Maybe it's either too long or it's not long enough. And really making sure that there's a separation of space so that there's adequate workflows so that you're not using the wrong brush. Because using the wrong brush on a different scope can result in the manufacturer having to report the issue to the mod database. So there's significant ramifications if this happens.
Yeah, those are some great considerations. I love that you mentioned the little clear package of brushes because I immediately that brought me back to my experience in the endoscopy rooms and the reprocessing rooms and all of that back in my former facility. And one of the things that is really important, you mentioned the length and all of that, and another one is the diameter of the brush, and it's very easy when you say you do the most of the time you're doing the same scopes, whether it's a colonoscope or an EGD, and those are like 90% of your scopes. And then you throw in a bronch or an ERCP or something a little bit different, and now you got to remember to go and get a different brush, And so it's like that rang true to me. It's like you gotta have your space organized, you gotta be able to see the right labeling and all of that stuff and take the time, to get the right brush. We talk about that stuff a lot here at Healthmark, so, we appreciate your your take on that. Um, Another one that, I'd like to ask you about is the AER, specifically the filters and things like that. One of the things I learned back in the day as a customer was the filters were enormously important. But as a clinician or even a reprocessor, it's not something that necessarily I thought about a lot, right? So I was just curious what your experience is with those filters and how are people to manage those things? What's the best way and who's responsible for that?
Well, that's where it gets kind of interesting. Who is responsible for that? And it could be your biomed departments, facilities, third parties, or even frontline staff. And looking at the specific AER, it's so important to have access to those user manuals, those service manuals, to understand what are the filters, what are the responsibilities, really focus on who your third party contractor is. So if you have the Medivation Advantage Plus, then Steris is the one that's coming in. Which filters are they managing? Which filters are the organization's responsibility? Sometimes, like you said, it's behind closed doors. You're not thinking about it. You see the ones on the wall, the pre-filters, those are really obvious. But when are those supposed to be changed? And that's one of the things that I really like to focus on because that's something that frontline workers can really see. This is IPs and managers, leaders, sterile processing technicians. Um, so those really should be changed every 6 months. But what we know is everybody has different water quality. And with ST1, ANI ST 108, now we're starting to look more at what is the quality of water coming into these systems. And each of those filters are not only keeping microorganisms out, but looking at that pore size to make sure that it can get down and really make sure that scope is ready to be used. Um, Looking at the PSI, you want to make sure that you have at least 40 PSI on your refilter, making sure that if it drops below that, then it's probably time for it to be changed. It's time to let maintenance know that's something maintenance can handle. And then looking at additional filters, one of the ones I really like to think about is um, the disinfectants that are used and the filter that's used to manage those odors, those smells, making sure that there's appropriate air exchanges. Um, yes, that's important. Is there a way to exhaust everything else? But if you're looking at specific filters, there are filters that manage those additional odors. And this can become an OSHA concern. We really want to make sure that everyone is safe working in these environments. Um, but also look at the different manuals. There's um, weekly, daily, monthly, quarterly maintenance that's required. And then understanding whose responsibility those are. Um, uh, Looking at some of the mesh filters, those are really important because those can trap different particulates. If that becomes an issue, then that should be cleaned out weekly. Um, but additionally, one of the really nice things about these AERs is that they're much more progressive technology wise, and they're beginning to alert the end user that there's something wrong. Could be a water flow issue, but also a daily observation, especially if you're using a Medivator Advantage Plus or a Medivator in general, looking at the water flow into that basin. This is something that you can see visually. And if there's an issue, then maybe the internal water filter needs to be changed.
I love that you talked about this process, and I can tell you as a reprocessor, I worked in HLD quite a bit, and we don't think about filters. We don't think about, water flow and changing these things out. We're focusing on reprocessing the scope. So there's things you don't think about. So somebody has to be the one to put that process in place and have these regular checks where those things are getting, changed out as needed. Another gap when we're talking, as long as we're on endoscopy, is the a gap in the process for sending scopes out for repair. As a tech, we would get a scope, maybe it would fail a leak test, maybe it would have some damage on it, whatever it was, we would just send it out. And that would be sort of like the end of the process. So how can facilities improve? Because these are really expensive repairs. How can they improve upon that process and think a little bit more critically about that repair process?
Um, Really work with those leaders. Understand why they're sending these out. What is the repair that's being performed? Um, this actually led me to look at things very differently. At first, you think maybe it's a tear, maybe it's, just general damage that's happening to these scopes. Um, but in some facilities, I've found actually the use of bite blocks. They had a lot of scopes that had bite impressions on it. And it came to, they'd switched from soft bite, reusable bite blocks to single use bite blocks. And the physicians didn't like using them. And this is where I really like to observe cases. I like to see what are these practitioners doing with these scopes? How are they using it and manipulating them? And then what are the practices with bite blocks? This was actually a really great opportunity once to have um, a respiratory technician, a respiratory therapist speak up and say, no, do not touch the scope until you put a bite block in the patient's mouth. So hearing that person being empowered in a hierarchical environment was really amazing to see. And it also took me back to the leaders to say, well, what's going on with these scopes? And it really came down to the use of bite blocks, and understanding the significant cost. Again, it's you just send a scope out for repair. It's gone for a while. It causes throughput issues. But you make do, and then you come back and you just use another scope. But since these are used in so many different areas in the OR, bedside procedures, as well as in the interventional rooms, you have so many different people managing these, and some of them are not necessarily the ones that are using them most frequently. So you might have some um, residents or fellows using these devices, and they're in a hurry. You've got throughput, you've got multiple cases you have to get through, and really understanding what the factors are. Particularly if it's cleaning, if you're using borescope technology and you're seeing that you have a lot of scratching, this maybe takes you back to look at what kind of brushes are you using? What is the process of using these brushes? So it really helps focus on the different aspects of what could be a breakdown in the process. How can you best support all teams involved, the infection prevention department as well as sterile processing?
Wow, those were some great examples. Again, kind of brings me back to my experience too. And when you when you mentioned the one about the bite block and the respiratory therapist having to speak up and make sure the doc put the bite block in first. It's funny because I think back on some of the things I saw, and this was, doctor, it could have been nurse, could have been surge tech, could have been sterile processing tech. None of us own the equipment, right? We don't purchase it ourselves. And there's an inherent risk in that we just don't treat it as we would as if it was our own. Like when you get a new car, you want to take care of it. You don't want to let your kid drive it, all these different things because they're gonna leave trash in it or get in a wreck or whatever, but, like, when it comes to this expensive hospital equipment that's used on patients every day, eh, you can't make your staff buy it. I mean, this is all really expensive equipment that we're charged and responsible for, but we don't have, like, that stake in it where we own it, you know what I mean? It's different. So, like, you see people do all kinds of weird things with really expensive equipment, and they just kinda, with surgical instruments, they might throw it in a case guard or whatever, and it's like a $10,000 scope or whatever. Flexible endoscopes are what, anywhere from 30 to $70,000 or something, and I mean, you just see them get roughed up throughout the day, and so I that's just stuff that really resonates with me. I think that there's probably a lot of people out there that have seen that. I know we used to use flexible endoscopes every once in a while in the operating room, and that was always an interesting thing because you have your endo people who are doing endo all day, and then all of a sudden the OR people are like, "What do I do with this thing? Can we get the endo people in here?" And, like, it was always like, "Oh, maybe they're available, maybe they're not," and you always wish that they were because that they're gonna do a better job taking care of that delicate instrument more so than we would, in the operating room where we're not as, you know, used to using it. So, but it was interesting too in your story how even the endoscopists who are doing it all the time sometimes have bad practices or need to do things a little bit differently to keep the equipment safe. So, um, before we wrapped up, I wanted to give you a chance to give any other final thoughts, but um, e even other than just final thoughts, even, I don't wanna put you on the spot, but, like, is there another sort of story from your career where all of this kind of, um, really hit you, where there were some sort of gap and it was just like, "Oh my gosh, no wonder this is an issue," and it really dawned on you, there was like an aha moment that you could share, with the listeners?
Oh, one thing that I found really interesting and um, alarming, but it's all an opportunity for learning. The use of disposable scopes. They are single use. There's two with a line through it. doesn't mean that you're going to bronch them again in an hour, so you save the scope. I was doing rounds one day and I noticed there was a disposable bronchoscope draped over the back of a sharps container. Well, first of all, there's a couple alarming things that you want to see. What's going on here? So I just asked the respiratory therapist, what can you tell me? You explain, what is your process? Why is this here? And he said, oh, well, the patient's been recently bronched, but we're going to bronch him again and see what else we can find. Would you do that with a regular reusable scope? Well, no, we do it with these because these are just quick and easy to get. So it was really interesting not only to see the thought process behind it, but um, to really see something in practice. Because of course, infection preventionists, we like to think of every way the process can fail. Um, but we really need that feedback from people to see what's their rationale to figure out how can we interject and how can we work on that. Um, and really started looking at when this patient is being rebronched, this is bacteria that's now environmentally transferred. We've had bioburden that's been allowed to grow and proliferate. So something that maybe was their own flora and not as concerning is now much more concerning. But also, how widespread is this? And this is where you can really start talking to these um, therapists. You can start talking to leadership and say, well, where is this person working? How pervasive is this practice? And then really look at education on what does it mean when it's a single use device? What does it mean for environmental contamination? And then when you get to the end point, what does it mean for the patient? Are they having positive cultures because it's something that we gave them, or is it something that actually is going on in themselves? So looking at appropriate treatments as well. So this is kind of a big one that I saw in organization. And at the end of the day, we're all trying to do the right thing, and just knowing where to look and who to talk to sometimes can be challenging. So you can start with maybe what procedures has this patient had, or what is the process for using these devices, and asking these probing questions in a very safe way that's non-punitive. Because if people feel, oh, my job's threatened, I'm going to be fired, then they're less likely to talk to you and open up. But really engaging that kind of open dialogue where you can see what is happening, how did we get to this point, and then you can start creating actionable change.
So many great points. I'm sure we could talk about gaps in the process all day long, but we'll let you go for now. But I did want to ask you before you go the name for your consulting business, because I'm sure people will listen to this and want to know more about it. So, what is the name of that business?
Thank you so much. It's Epidemiology Loves Solutions, because that's something that we're always looking for is solutions to problems, but we like to call them opportunities. So it's Epidemiology Loves Solutions Consulting.
Awesome. Emily Barnard, thank you so much for being on the podcast. Really enjoyed it. And we'll see everybody on the next one.
Thank you so much. It's truly a pleasure. Have a good day.
Bye, everybody.
All opinions expressed on this episode are those of the presenters. This podcast is for informational purposes only.
Before using any medical device, it's important to review the manufacturer's instructions for use and consult with a professional.
For any questions or feedback, please reach out to us at asktheeducator@hmark.com.